Hello, everyone. I'm Dr. Chen Huang-Chi, and I'm the chest medicine physician and the intensive care unit physician in Yuanling Christian Hospital. Today, it's a very honor to have a talk about the diagnosis and the treatment of lung cancer. As we all know that the lung cancer is a very difficult to treat disease before because we do not have a good drug and treatment modality before. But these years, we have a great advancement in the diagnosis and the treatment. Therefore, today I will have a introduction about diagnosis and treatment of lung cancer. And let's move on to the next slide. We all know that internationally, lung cancer continues to be the leading cause of cancer-related deaths in men and women. And lung cancer incidence and mortality are tightly linked to cigarette smoking. And the association of air pollution and lung cancer is also a hot issue recently in Taiwan. This figure shows in 2012, the incidence of mortality of lung cancer is quite high in many countries, such as Hungary, America, etc. Many studies show that most relevant problem is the cigarette smoking. Lung cancer survival is lower than other common malignancy in Europe and the United States. This is because patients with early lung cancer usually do not have symptoms. Even the patient have chronic cough. Most people will regard it to be due to irritant of cigarette smoke, or maybe they have chronic bronchitis. Therefore, when patients have severe symptoms related to lung cancer, usually they are found to be in late stage. In Europe, all lung cancer patients diagnosed in 2000 to 2007, the mean 5-year survival is only about 13%. This survival data reflect the dark ages before because we did not have good treatment for lung cancer at that time. Therefore, early detection is very important. This famous study was published in the New England Journal of Medicine. This is about the screening for lung cancer. And we can see that the study was conducted in the United States and is focused on the population of patient he or she smoke 30 packs per year. And why we do the chest CT scan? Because we usually use chest X-ray in our routine examination. However, we know that there is limitation in chest X-ray. We usually cannot find a lesion smaller than 5 millimeter. And we also might miss a very faint lesion, such as like this, very faint lesion. We said this is ground glass opaque lesion, GGO. And the very faint lesion might not be seen or find in chest X-ray. Via CT scan, with a better detection rate, we can find a very small lesion. And this study showed that via CT scan screening, we can reduce the mortality of lung cancer. This is one of the guidelines for CT detected nodule at screening. if a patient received a low-dose CT scan and we found a nodule smaller than 4 millimeter, then we will advise continue annual screening. If the nodule is the size is between 4 to 10 millimeter, we will advise a shorter duration of follow-up, maybe 3 to 6 months. However, if the nodule is greater than 10 millimeter, then we will advise tissue proof biopsy to find out if the lesion is malignant or not. If cancer is diagnosed, then definite treatment, such as surgical resection, would be recommended. How we define lung cancer is early stage or late stage. This is we currently use for lung cancer staging, and we usually adhere to the 8th edition lung cancer stage classification. This system is proposed by the International Association for the Study of Lung Cancer. And this previous study is conducted by the International Multi-Specialty Staging and Prognostic Factor Committee. And the database was based on the patient total number around 95,000 patients. And through extensive statistical analysis of the database, the proposal of the stage classification is related to the prognosis. And we can see here that early lung cancer have good prognosis. You can see that 1A stage and the 1B stage is related to relative better prognosis. But the patient with 4B stage, it is related to poor 6-year survival. The staging system is based on T&M system. T is tumor. As you can see, T1 means the tumor size is not greater than 3 centimeter. And the T4 means the tumor size greater than 7 centimeter, or tumor invaded mediastinum, diaphragm, or major organ. And the N is the involvement of the lymph node. If the lymph node could be found in the contralateral side mediastinum, then we will define it to be N3. And M is with or without metastasis. This is lung cancer lymph node map. It is very helpful in surgery and image study. This table shows the stage group according to T and M descriptor and the subgroup. If the patient's tumor size is greater than 7 centimeter, the T will be T4. If the patient's N lymph node, there is no lymph node and no distant metastasis, the stage will be 3A, for example. This is the graphic illustration of stage 0, 1, and the 2. This is graphic illustration of stage 3A, 3B, and 3C. And this is graphic illustration of stage 4A and 4B. To accomplish the clinical staging, we still need the following imaging study. I think the most important is chest CT scan, and I will advise to arrange chest CT scan with and without contrast medium in the same exam. And you can see in the picture there is a irregular mass lesion and invade to the great vessel. And in the picture, we can find a lymph node here. By using contrast medium, we can differentiate the lymph node and the vessel because contrast medium is inside the vessel. So we can differentiate lymph node and the blood vessel. And we also use the long window. Using long window is very good tool to detect lung parenchyma lesion and to detect such like this very faint lesion, ground glass opacity lesion. And we also use brain MRI with contrast medium to detect the possible brain metastasis and leptomeningeal carcinomatosis. And you can see here the MRI at the right side. It is better than brain CT scan to detect the metastatic lesion. This is the PET CT scan. It can also detect hypermetabolic lesion such as lung cancer and metastatic lesion. It could also be used to evaluate the treatment response. Bone scan is also used to detect the possible bone metastatic lesion. After confirmation, the pathology result and the staging, we will go back to the treatment guideline. We usually follow the recent treatment guideline. This is the recent NCCN guideline for lung cancer. And we can see they are divided to two parts. One is for non-small cell lung carcinoma, including adenocarcinoma and the squamous cell carcinoma. The other part is small cell lung carcinoma. With the advancement of the treatment, we find the overall survival is improving. In 1960, we only can give patient support care, and you can see that the mean overall survival is very short. With the advancement in treatment, we find that the overall survival is improving. And for the patient with early stage lung cancer, I think surgery is still the priority because surgery can remove and resect the tumor, and it is the only possible way to really cure the patient. There is also great advancement in chest surgery. You can see the graph here. Long ago, we can only give patient pneumonectomy, but nowadays we can give patient very minimal invasive procedure to perform lobectomy or even sublobar resection. This is a picture of video-assisted thoracoscopic surgery. We only need one or two very small wounds, and the surgery could be accomplished very safely. In certain patients' condition, such as a very too old patient, they may have many comorbidity. They may be too old or too fragile to receive surgery. Then radiotherapy, such as HBRT, is also a good choice. While computer and program planning the tumor will receive adequate radiation, and in the meanwhile, other vital organs, such as heart, will receive less harmful radiation. In selected patients, radio frequency ablation is also used for treat the peripheral lung tumor. And we know that there is a wide spectrum in stage 3 lung cancer. In stage 3 lung cancer, the tumor may be very small and it may be resectable, but the tumor might be very large and could not be resectable. And therefore, multidisciplinary team and meeting are very important, even for the case with very early stage or terminal stage of lung cancer. In multidisciplinary meeting, we have chest surgeon, chest physician, pathologist, diagnosis radiologist, radiation oncologist, medical oncologist, and the pathologist to attend the meeting together. Let's go on to see the systemic treatment. There are 4 kinds of systemic treatment: chemotherapy, targeted therapy, immunotherapy, and antiangiogenesis. Before we start the systemic treatment, tissue proof is needed. We must confirm the pathology result. Different cell types need different treatment. In other words, the best treatment for lung cancer is quite different to squamous cell carcinoma. We can use surgical resection to obtain the tumor specimen. We also can use CT guide biopsy for the peripheral lung cancer. In this figure, we can use bronchoscopy and endobronchial ultrasound to get the tissue. And let's go on to the chemotherapy. Traditional chemotherapy agents are cytotoxic by means of interfering with cell division, but cancer cells vary widely in their susceptible to this agent. In lung cancer, the most common used regimen is platinum-based chemotherapy. Targeted therapy refers to use agent specifically designed to selectively target molecule pathway responsible for the malignant phenotype of lung cancer cell. Briefly speaking, and if possible, we need to find a driver gene in the tumor cell and then select a corresponding effective drug. This figure shows what we routinely do in our clinical practice. We confirm the tumor cell type and then use IHC, FISH, or DNA sequencing to find the possible driver gene. This figure shows in the left side are 4 members of ER-BB family of receptor. All 4 members of this family have tyrosine kinase domain in the cytoplasmic portion of receptor. And you can see at the right side, right portion, it shows that binding the ligand induces dimerization of the receptor, and the dimerization results in phosphorylation of the tyrosine residue of the EGFR kinase domain, then it will activate a wide array of intracellular signal cascade, inducing cellular proliferation and angiogenesis. Panel A, shown here, is the targeted therapy to EGFR tyrosine kinase, erlotinib, and gefitinib. Panel B shows that intracellular binding of the erlotinib to the ATP binding site of the tyrosine kinase domain of EGFR, which block the subsequent downstream signal or pathway responsible for cellular proliferation. As time goes on, we found several driver oncogenes, and there are more and more effective corresponding drugs we can use. If the tumor gene is EGFR positive, we may choose gefitinib, erlotinib, or afatinib to treat the patient. And if the driver oncogene we found is ORC positive, we may choose the drugs such as alectinib, ceritinib. And if ROS1 is positive in Taiwan, we will choose crizotinib. When treating infectious disease, the problem we will encounter is the drug resistance of antibiotic. It is the same when we treat lung cancer. If the patient's tumor gene is EGFR positive, initially we may choose the first generation or second generation of TKI. However, maybe about 1 year's treatment, there might be an acquired T90M mutation. Then the original drug will not work properly because for the drug resistant, then we will need to change to the third generation TKI. It is the same in ORC positive patient. We have the first generation, second generation, and the third generation ORC TKI inhibitor, and they are all available in Taiwan. Let's move on to the immunotherapy. In our immune system, we can detect the tumor cell and kill the tumor cell. When the tumor antigen is found by the antigen-presenting cell, the APC will activate T cell via T cell receptor and MHC, and also via CD28 and the B7 interaction. Via this pathway, the T cell is activated, then the T cell can kill the tumor cell. However, if there is PD-1 and the CTLA-4, PD-1 and the CTLA-4 could block the immune system, leading to tumor cell not being destroyed by the immune system. By using anti-PD-1 and the anti-PD-L1, we can reactivate the immune system to kill the tumor cell. In Taiwan, we now have several immunotherapy for lung cancer, such as nivolumab, pembrolizumab, atezolizumab, and durvalumab. The last one I will mention is the anti-angiogenesis. Malignant cell and inflammatory cell will release VEGF. VEGF will bind directly to VEGF GFR receptor 1 and 2, then interact with NRP. It promotes the angiogenesis and the tumor growth. By using anti-angiogenesis drug, we could normalize the vascular bed around the tumor. Therefore, we could find we can get the following benefit by using anti-tumor angiogenesis, such as inhibition of the growth of new vessel, regression of newly formed tumor vessel, alteration of the function of the vascular bed, and the direct effect on tumor cell, including the inhibition of anti-apoptotic autocrine signal. Finally, I will recommend you have a copy of this article. After reading this review article, I think you will have a comprehensive understanding of the shifting landscape for lung cancer from past to present and to the future. You can see here in the graph, this is the timeline depicting milestone in lung cancer. And this is the future opportunities to impact the prevention, detection, and the treatment of lung cancer. Thank you for your attention.